Thank you. Good morning. My name is Carl Lissman. I am a WM patient and was diagnosed in 2017, so almost 6 years for me. I serve on the Board of Trustees as the Secretary-Treasurer, and I've been a member of the board for 3 years. I live in the Philadelphia area with my wife. Our 3 children live reasonably close to us, and our 4 grandchildren, therefore, are also reasonably close to us, which keeps, honestly, my wife more busy than me. This morning, it's my pleasure to introduce Dr. Jonas Paludo. He is an assistant professor of medicine and oncology at the Mayo Clinic in Rochester, Minnesota. Dr. Paludo is a member of the lymphoma, cell therapy, and stem transplantation disease groups at the Mayo Clinic. His research work focuses on translational and outcomes research in lymphoid malignancies, with a dedicated interest and work in Waldenstrom's macroglobulinemia. Unfortunately, the handout of the slides for Dr. Paludo didn't arrive in time. They will be here this evening, so they'll be available late tonight or tomorrow for you to pick one up. In the meantime, we'll ask you to pay close attention to Dr. Paludo's slides, because he, in fact, does have them on the screen, thankfully. So with that, please welcome Dr. Paludo.
All right, good morning, everyone. All right, I'd like to thank you, the IWMF, for the invitation to speak here today. It's always my pleasure to be here, especially talking about Waldenstrom's. So today we'll talk about the current treatments and some of the new potential therapies coming on in the Waldenstrom's space. So over the next 40 minutes, we'll cover 3 main points today. We'll be reviewing the most common current treatment options in Waldenstrom's. We'll talk about potential coming therapies in the near future, and then we'll wrap up talking about some of the importance of participating in clinical trials. So the first section here, talking about the most common current therapies. I do have a few disclaimers to make here before we start. So the treatment indication for Waldenstrom's, which is a very important topic of discussion, has already been covered, so I won't go into that. We'll start from the assumption that we talk about treatment as if you need treatment. The available treatment options for Waldenstrom's can really be limited based on geographic locations and based on insurance approvals, government regulations. So we'll be talking about options that are available in the US that may not be applied to every different other country. And I only selected a few options to discuss today. There are several other treatments that are not included in the presentation today that are used, were used, and may be used in the future for Waldenstrom's. So with this in mind, let's move on and start with a brief summarized timeline of treatment development. So we know Jan Waldenstrom's described this disease in 1944, 1945. For several decades following that, only chemotherapy were options available for Waldenstrom's. Those are treatments borrowed from other diseases. And as a matter of fact, back in the 60s, 70s, 80s, there were not many options available for any kind of disease or cancer. In the early 90s, that's when rituximab was developed. It showed very good activity in B-cell lymphomas, including Waldenstrom's. And that's the reason why you see that rituximab has been added to almost every single regimen that came after that. Around the early 2000s, DRC, which stands for dexamethasone, rituximab, and cyclophosphamide, was actually the first regimen that was primarily designed for Waldenstrom's. BDR is another example. A few years later, we had BR, or bendamustine and rituximab regimen that was developed and showed a very good activity in patients with indolent lymphomas, indolent non-Hodgkin's lymphomas, including Waldenstrom's, and became our preferred chemoimmunotherapy regimen from that point forward. Around 2012, 2013, the BTK inhibitors, ibrutinib being the first one, were developed, and they show very good activity in several malignancies, including CLL, some other lymphomas, and a remarkable activity in Waldenstrom's. Zonobrutinib is another BTK inhibitor that was recently approved for Waldenstrom's. So before we dive into the specific regimens and talk more in details about each one of them, there are different ways that we can classify them. We can classify based on the duration of therapy, and we heard a little bit before about the fixed duration treatments. Those have a start date and a predefined end date. Or we can call them continuous therapy when they start date, but there is no predefined end date. They continue for as long as they're working and for as long as they are tolerated. We can also classify the treatments based on the drugs or the drug types that are in each regimen. Chemoimmunotherapy, so chemo combined with immunotherapy, or target therapy. So with that in mind, we'll now review some of the most common used regimens at this time. So the first one I have here, and I have summary cards, I guess, for each of these regimens. So the first one I have here is BR, or RB, or BAND-R, R-BANDA, all different ways to call the same regimen that essentially consists of a combination of bendamustine, a chemo drug, with rituximab, an immunotherapy drug. It is one of the most commonly used chemoimmunotherapy regimens in Waldenstrom's because of its high activity or high efficacy with overall well tolerability or good tolerability. It is our preferred regimen when you're looking for a deep response, meaning when we're trying to eliminate as many or as many of the cancer cells and as much of that IgM protein as possible, such as in situations when someone has amyloidosis concomitant with Waldenstrom's or for some other IgM-related complications. It also works very quickly at killing the cancer cells. So in those situations, there's a lot of cancer cells and you need to decrease that quickly, BR is a good option for that. Here in this box here, you can see it says the schedule of BR is given for 2 days in a row, every 4 weeks, for 4 to 6 cycles. So the average treatment duration is about 4 to 6 months, depending on how many cycles. If you look at the efficacy, overall response rate, which is here, essentially is the proportion of patients that have at least a minor response. So every proportion of patients that are responding to treatment, you can see here is quite high, in the 90 to 98% of patients have some improvement with this treatment. The average duration of that improvement or the average duration of that response is a median of 58 to 69 months, so about 4 to 5 years. Most common side effects or serious side effects, as with any chemo drugs, low blood counts, increased risk of infection, fatigue, those are common side effects of chemo. Infusion reactions can be seen with rituximab, usually with the first infusion, and then it gets better. Special considerations here, I did include one of the common questions we get about chemotherapy options. Any chemo drug has a theoretical risk of causing a secondary form of blood cancer, usually MDS or AML. Several studies have been looking into the potential risk of that. It's really difficult to define, and there are some limitations to each study, but when they're trying to define what's the risk of bendamustine causing one of these malignancies, studies have reported from 0% to 5% risk of a secondary blood cancer. So BR is a fixed duration, it's an IV infusion, is a chemoimmunotherapy regimen. So the next one I have is a DRC or RCD. It's a combination of dexamethasone, a steroid, rituximab immunotherapy, and cyclophosphamide, a chemo. This is another fixed duration. It's an IV oral treatment. It's a chemoimmunotherapy regimen. It's a preferred regimen when we are aiming for low toxicity. It's easier to tolerate than BR. Usually for those patients that may not be able to tolerate bendamustine or rituximab, or those patients that have a small amount of disease, of tumor, that don't need to be taken care of quickly. It is an IV infusion for 1 day with 5 days of tablets for the cyclophosphamide. That's done every 3 weeks for 6 cycles, so about 4 to 5 months in total. The proportion of patients responding, the overall response rate, 78 to 90%, and the average duration of that response, it's also about 51 to 59 months, so close to 5 years. Common side effects are similar to BR that we just reviewed, just at a lower intensity and lower frequency. And the same as with BR, that potential risk of secondary malignancies has been reported ranging from 0 to 3%. So the next one here is a little bit different. So now we're talking about BDR or RBD. Not to make things any much easier, but B here is not for bendamustine, it's for bortezomib, also known as Velcade. Bortezomib is not a chemo, not like cyclophosphamide or bendamustine. Bortezomib is what we call a proteasome inhibitor. Not quite a target therapy, but it does work in the cell and works by disrupting the protein degradation and turnover. It's like if you're shutting down the trash removal system of the cell. And the trash is accumulating, and that is causing the cells to die from that mechanism. BDR is a very good alternative for patients that are looking for a fixed duration treatment without a cytotoxic chemo drug. It works quickly and has a very good efficacy. As we can see here, the schedule is a bit complicated, I'll be very honest. There are subcutaneous injections every couple weeks, twice a week for a couple weeks, and weekly for 4 months. You have IV infusions in the mix for 2 months, broken down into 2 blocks. But essentially, it's a 5-month treatment with some sort of a treatment, an infusion or injection every week. The efficacy is very good, with response rates in the 84 to 96%, median duration of response also approaching 5 years. One of the common side effects here is peripheral neuropathy. As we know, Waldenstrom's can cause peripheral neuropathy, so we have to be cautious in those patients that already have neuropathy, either from Waldenstrom's or maybe from other disease like diabetes. So we try to avoid bortezomib or bortezomib-containing regimens in those situations. So it's a fixed duration treatment, it's an IV subcutaneous infusion injection using a proteasome inhibitor and an immunotherapy. So here's my first side note to talk about this formula of proteasome inhibitor, steroid, and anti-CD20 monoclonal antibody rituximab that has been repeated a few times. BDR was the first one that we just reviewed. Carfilzomib, daxrituximab, or ixazomib, daxrituximab are 2 other regimens following the same formula. They were developed in a way to try to minimize some of the toxicities of the bortezomib and try to facilitate that complicated scheduling or schedule of treatment. They all have equal efficacy, they all have quick responses, they all have similar activity, but they all have slightly different side effects or side effect profiles. So bortezomib, as we mentioned, peripheral neuropathy. Ixazomib can also cause some neuropathy, but also infections and infusion reactions. And carfilzomib has a very low, but there is a well-described risk of causing some cardiomyopathy, which is heart toxicity. All right, now we're moving on to the next part of immunotherapy. So rituximab. I have here rituximab monotherapy or rituximab alone. It's a fixed duration treatment, it's an IV infusion, as I mentioned, it's an immunotherapy. Rituximab alone or monotherapy is a very well-tolerated treatment, but it has limited activity or limited efficacy. So rituximab is a monoclonal antibody that's designed to bind the CD20 marker. It's a surface marker on the cell, on the surface of the Waldenstrom's cancer cells. So when you infuse rituximab tags that marker on the cancer cells, and that is a signal to your immune system to say, this cell is abnormal, it has to be destroyed. That's why it's called an immunotherapy, because it uses your own immune system to kill the cancer cells. As I mentioned, rituximab has some limited activity because it has some limited efficacy, but we usually consider that as a monotherapy in patients that have a hemolytic anemia or neuropathy without another reason to require treatment. Now, it used to be more commonly used in the past when we were trying to avoid chemo, or on older patients that could not tolerate chemo, rituximab was the alternative. Now that we have BTK inhibitors, they're also an alternative to chemotherapy with much better efficacy. We tend to favor that when you don't want to use chemo. So rituximab monotherapy is losing its role or has a diminished role in the future of treatment of Waldenstrom's. It still works, it's still valuable, but used alone, it's losing its role in that space. It's an IV infusion once a week for a month, sometimes given for 2 months. The efficacy, the response rate is only 50%, and the duration of that response is about 2 years. So overall the efficacy is half compared to the other treatments we're talking about today. It can cause infusion reactions, as I mentioned before, usually with the first infusion, and the IgM flare phenomenon, which is a rise in the IgM after the infusion, can be seen as well. It's usually not a problem unless you're already starting with an IgM high, usually above 4,000, that further increase in the IgM, or that flare, could be enough to trigger that hyperviscosity or hyperviscosity syndrome. Special considerations include here the very, very rare risk of a difficult infection to treat called PML. All right, moving on to the target therapy. So now into the continuous therapy, oral regimens, target treatments. Ibrutinib is the first one I have, was the first BTK inhibitor. It's a very well-tolerated regimen and has very good efficacy. It's called a target therapy because it's specifically designed to block a protein, the BTK protein. That's why it's called a BTK inhibitor. Now, why does the BTK protein has anything to do with Waldenstrom's? Well, the BTK protein triggers a pathway inside the cell that tells the cell to multiply and to grow. That's kind of the cancer, that's kind of how the cancer behaves. It turns out that the BTK protein is activated by the MYD88 protein. That's a much more familiar term, the MYD88 protein or the MYD88 protein. We know that the majority of patients with Waldenstrom's have a mutation in the MYD88 protein in the cancer cells. That mutation makes that MYD88 protein always turned on, always activated. In turn, that always activates the BTK protein. And so forth, intracellular pathway makes the cancer cells to grow and multiply. So by blocking the BTK protein, you're blocking that mechanism. That's why the BTK inhibitors are so effective and important in Waldenstrom's. And that's also the reason why they tend to work better in those patients that have the MYD88 mutation, which again is the majority of patients, more than 90% of the time. It is an oral treatment. It's taken daily. There is no end date. The treatment is continued for as long as it's working and for as long as it's not causing enough side effects that justify it to be discontinued. The efficacy, as you can see here, the response rate is 90%, 50% for those without the mutation, for that small proportion of patients that don't have the mutation. The duration of efficacy is in the order of 39 months as a median, but it can be even much higher than that for patients with mutation. Again, those are most patients with Waldenstrom's. And at 18 months, 88% of patients are free of relapse or free of progression. It's just another way to look at duration of efficacy. So some of the common side effects here, we have low blood counts, hypertension. There was a question earlier about hypertension, some joint pain, and atrial fibrillation. And as special considerations, again, being cautious with using these if you already have a predisposition to develop some heart arrhythmias or have a risk of atrial fibrillation. And there is a potential risk of withdrawal or IgM flare, not when you start, but when you stop the drug. In approximately 20% of the patients on ibrutinib, when you stop the ibrutinib, you can develop a withdrawal phenomenon, usually presenting as maybe fevers, maybe night sweats, maybe headaches, joint pain. That goes away when you start the ibrutinib again, and there's a risk of the IgM going up when you stop the medication. Again, it comes down when you resume the medication. So ibrutinib is our first BTK inhibitor. So here I have another side note. So this side note is to talk about the INNOVATE clinical trial that randomized patients to compare the efficacy or the treatments with rituximab alone compared to rituximab plus ibrutinib. Patients that received the two drugs together had better efficacy, had a higher response rate and a longer duration of the remission. Now that's not surprising at this point, as we just talked about rituximab monotherapy and ibrutinib, and I just mentioned that ibrutinib has activity on its own, better than rituximab alone. Of course, when you combine drugs, you also combine side effects, and patients on the combination treatment in this trial had a higher rate of side effects. Those are side effects that we usually see with ibrutinib. So my take from this trial, it's looking at it at a different angle, not the exact angle that the trial was designed for. But my take from this trial is that adding rituximab to ibrutinib doesn't add much efficacy to ibrutinib on its own. So usually when I think about using ibrutinib, I usually think about using without rituximab because it does not seem to be adding much benefit. It does add on the cost, it does add on the logistics, it does add on the side effects. All right, so the next one here is zanubrutinib, another BTK inhibitor similar to ibrutinib. It's another continuous oral target therapy. Has a very good efficacy comparable to ibrutinib, has a different side effect profile. And I'll talk about that more in a second. The schedule is also an oral treatment, is taken without a specific end date. The efficacy, as you can see here, is very, very similar to ibrutinib, with the exception that it may have a slightly higher efficacy in patients without the MYD88 mutation. Okay, that's a small proportion of patients. Common side effects, low blood counts and potential risk of infections, and the special considerations are including increased risk of neutropenia, which is a form of white blood cell. So here's my third side note, which is to talk about the ASPEN clinical trial, which compared ibrutinib versus zanubrutinib head-to-head. So some patients were randomized to ibrutinib, some to zanubrutinib. As you can see here, the efficacy is pretty much the same for both ibrutinib and zanubrutinib. The side effects I included a few because they're slightly different between the two drugs. There was a higher rate of atrial fibrillation and hypertension with ibrutinib compared to zanubrutinib, but there was a higher rate of neutropenia, low white blood cell count with zanubrutinib compared to ibrutinib. Similar difference here in major bleeding, and you can also see here the discontinuation rate being a little lower with zanubrutinib. So similar efficacy, difference in the common side effects, and for that reason that is the main reason why we tend to favor zanubrutinib these days as our first BTK inhibitor. But one caveat here is that if you are on ibrutinib and if you're doing well, tolerating it well, there is no reason to change. All right, I have here a special circumstance. I want to include transplant because we often don't talk about transplants, and hopefully we'll be talking less about transplant in the future. But transplant is still a very effective option for a group of patients with Waldenstrom's. This is not for everybody. It's usually for those younger patients, they are fit, they have already gone through the standard treatments with chemoimmunotherapy, with BTK inhibitors, and may not have many options left. Transplant is still a reasonable option to consider. It's a fixed duration treatment. It's essentially high-dose chemo. It's only done once. It's also a reasonable option to consider if there is amyloidosis in the picture, not just Waldenstrom's. Again, it's a good efficacy, as you can see here with a response rate of 85 to 87%. The duration of efficacy is in the order of 5 years. It's a one treatment which includes the pre-assessment, the transplant, the recovery. It's about a 6 to 8 week period. Side effects are usually the side effects that we see with chemotherapy, with low blood counts, increased risk of infection, fatigue. And I included here just to highlight that it has a no-relapse mortality, which means the risk of dying from a complication of the treatment itself, not the disease, in the order of 4%. So again, it's not for everybody, but still a valuable option for a group of patients, and should not be taken off the table without due consideration or discussion with your doctor. As I mentioned, special considerations for selected cases. All right, so here are some other treatments that are commonly used that I have not included in the discussion today for sake of time. And with that, I'm moving on now to the second part of the discussion, to talk about potential new therapies. Now here I'll review some of the treatments that have been through clinical trials on patients with Waldenstrom's and have shown some good activity and some good results, and maybe coming to be part of our standard treatment options in the near future. I'm not reviewing treatments that have not yet made to that point. So there are a lot of other therapies that are not included here. They're still under investigation. So going back to the BTK inhibitors as a theme of the talk today, we talked about ibrutinib and zanubrutinib. I mentioned acalabrutinib. There are two other BTK inhibitors, tirabrutinib and orelabrutinib, and I don't know who came up with the names, but they're not getting any easier. They're getting more complicated as we go along. So these two other BTK inhibitors, tirabrutinib, for example, was investigated in a clinical trial showing some good activity in Waldenstrom's. Again, an oral continuous therapy. As you can see, the side effects here as low blood counts, skin rash, pneumonia, and mouth sores. I look at tirabrutinib and orelabrutinib as very good alternatives to BTK inhibitors, alternative to that patient that has not tolerated a prior BTK inhibitor. Let's say you're on zonabrutinib and had side effects and had to stop. Here are two potential options that could be used following that. The same for the orelabrutinib, very similar to the previous one, good efficacy, similar side effects, oral continuous therapy. Again, I look at these as two additional options that if you cannot tolerate a prior BTK inhibitor, you could use one of these options to continue on that therapy. The next one here is a slightly different one. This is pirtobrutinib. It's part of a new group of BTK inhibitors called non-covalent BTK inhibitors. Recently approved by the FDA for patients with mantle cell lymphoma, and hoping that soon will be also for Waldenstrom's. But the excitement around pirtobrutinib is that it showed some activity in patients that had disease relapsing after a prior BTK inhibitor. So being on ibrutinib or zonabrutinib and the disease progressed on that is another option that may work well in that setting. So that's all the excitement around pirtobrutinib. The next one here, which is maybe not quite a novel therapy, but the BCL2 inhibitors, venetoclax, a target therapy that blocks the protein BCL2, which is part of a different pathway inside the cell that also stimulates the cancer cells to grow and multiply. Venetoclax has been studied in Waldenstrom's for a few years, and it has shown very good activity. And it's also another option, another good option to be used once the Waldenstrom's has progressed or relapsed while taking a prior BTK inhibitor. So until a few years ago, venetoclax was the only one available. Pirtobrutinib may be the second one in the near future. So good option. It does cause a lot of low blood counts, though, and the risk for infection. So it's a good option, but not free of potential side effects. Next one I want to highlight today is again in the target therapy, is the PI3 kinase inhibitors. Idelalisib was recently investigated in combination with obinutuzumab. Obinutuzumab is a monoclonal antibody like rituximab. They're essentially the same. They have a similar mechanism of action. And what's interesting in these studies is that this drug or this regimen was used for a fixed duration of therapy. So it's a fixed duration treatment without chemo, using target therapy and an immunotherapy that shows some very decent efficacy and tolerable side effects. So it's another good option for potential good option when you're looking for a fixed duration treatment that does not have a chemotherapy on its own. Another one now, but this is for the special circumstances group. As we heard in the previous presentation, some patients with Waldenstrom's can develop cold agglutinin disease. That's a type of anemia that the IgM protein can trigger or can cause when associated with cold. Recently, a medication called sutimlimab was approved by the FDA for the treatment of cold agglutinin disease. It's an anti-C1 monoclonal antibody. Show very good efficacy. It's a fixed duration IV infusions for that. So for that special group of patients with Waldenstrom's, they have cold agglutinin disease. Now there is a new option, a new treatment that can be used for that situation or for that indication. All right, so not every trial is a home run. Here are some examples of some treatments that have been investigated that did not show as high of efficacy as we were hoping for, or showed some additional side effects that we were not expecting. I did debate whether or not to include this slide here, because I don't want this to be seen as a disappointment. I want to highlight here is that even when the results of a clinical trial are not as good as we hope for, there is still a lot that we can learn from it. We learn about how the drugs did not work, so we can design better studies. We learn about what side effects were unexpected and developed so we can prepare better for the next treatment that we're developing and for the next treatment combination. So every trial, no matter the results, it is a step forward towards a better treatment for Waldenstrom's and hopefully getting closer to potentially being able to say that Waldenstrom's is a curable disease. I will use that as the introduction to my next part and the last part of the discussion today, which is the importance of participating in clinical trials. So there are several advantages to being in a clinical trial. You can think of advantages to the individual taking part in the trial and advantages to the community in general with that disease. As an example to advantage to the individual, here include data from a study with patients with breast cancer, but I think we can extrapolate that to other diseases, including Waldenstrom's. In this study, it showed that women with breast cancer that were in clinical trials lived longer than those that were not. Now, there are several potential explanations here of why that's the case, but it just highlighted that there is some benefit for the individual taking part of the clinical trial. Some of the other advantages to the individual taking part in the trial, to the patient enrolling, is that you're getting early access to some of the newer drugs or treatments that could take years before they go through all the regulatory steps and the FDA approval process and become available as a standard option. It is an option, a way to get free medication, at least investigational drugs, and we know treatments are getting more and more costlier these days. And more important, you're preserving the established treatments, the ones that we have been reviewing so far for later use, and expanding your treatment options. Why is that important? So far, Waldenstrom's is an incurable disease. So the more treatment options we have, the better. We don't want to run out of options. So preserving the options for later use is always a smart and wise decision. And also keep in mind that all the things that we're just discussing so far, they are there because of clinical trials and because of all of you that have been part of clinical trials, being able to make it possible for everybody else. So for that, we're very thankful and grateful. So you should always consider a trial if that makes sense for your case, if that makes sense to the disease state that you are now. How to find clinical trials? First, and the easiest way is just talk to your doctor. Is a trial available? Is it the right choice for me? The IWMF website has a very helpful and nice highlight of clinical trials that's also easy and tailored for Waldenstrom's. But you can also go to the clinicaltrials.gov website, which is the overall all-encompassing trial repository. Every trial in the U.S. has to be registered in that clinicaltrials.gov website, so you can also find there. I think I'm coming up to the end of my presentation, so just to recap, there are a broad variety of multiple treatment available for Waldenstrom's. We have never had so many treatments now as we had in the past. We need to consider the efficacy, we need to consider the side effect profile when selecting the best treatment. What might be your best treatment now may not be for your neighbor or may not be for you in the future. There are several potential new treatments coming up, and there are many more that I even talked about yet. And always consider a trial if that makes sense and it's available. Thank you.
Thank you, Dr. Paludo. That was an excellent, concise, understandable summary of where we are in our many treatments and what's potentially coming. So very well done. Thank you. So Dr. Paludo has time to take about 15 to 20 minutes of questions. We have 3 microphones set up, one in the middle and one on each of the side aisles. And there are microphone covers. People are wondering what those little plastic containers are in the end. Those are actually microphone covers if you'd like to use one on a microphone when you're asking your question. So if you line up on the sites, and Dr. Paludo, can you see well enough to be able to point to one or another?
I think so.
Okay, very good. Well, we'll leave it in your hands.
Okay, thank you. All right, I see a line here.
I was in one of the clinical trials that you showed that are no longer potentials. What I didn't realize when I entered the clinical trial that typically there's a 1% threat of death, and that's actually what happened in my clinical trial. It was stopped as an emergency. But I've been off any medication since the trial stopped after about 8 months, and I am stable. I have had to have no treatment. So it seems to be doing its thing and causing cancer to behave. But clinical trials have that small percentage that it's scary.
Absolutely. Thank you for sharing that with us. And I think you're making a good point, is that the decisions on which trials move forward or stopped or discontinue, it's based on the overall assessment of everybody in the trial, right? So we look at the group results, but the individual result is different. Some patients benefit a lot from a clinical trial in a drug that worked well, didn't cause the side effects that we see on some other patients. So it's still, that's why I say, every trial is a good trial, even if we don't see the results we're hoping for. So it may not work for everybody, but still works for a group of people. So thank you for sharing that.
So I have I'm sorry, do you want to go over there? Go over there.
Okay, let's go over there then.
Hi. You had mentioned withdrawal symptoms for ibrutinib. Any related to some of the other treatments like zanubrutinib?
Yeah, so it can be seen in the BTK inhibitor class. Ibrutinib is the one that has been around the longest, so we know more about ibrutinib than we know about the other BTK inhibitors. It has been better described with ibrutinib, but it can be part of the BTK inhibitor as a class of drugs.
Okay, thank you.
Thank you.
Hi. So I've never had BNR. I started with Imbruvica and rituximab, failed on Imbruvica within 2 months because of AFib, and went into ARB maintenance for a year, and then relapsed within a year from that. So I'm on zanubrutinib now, but within 6 months, my neutrophils crashed, and I'm on half a dose. My symptoms are just kind of bordering, kind of tipping over to the other side, and I've also had gout, which I understand is another side effect, along with my platelets crashing. So the question is, where do you go? And I'm also wild type, supposedly. So where do you go from there? Should I go back to BNR, which I've never tried, which supposedly does a deeper response, or try one of the new drugs?
That's a great question, and we probably could take an hour to go over that discussion. It's you bring the question of, should we adjust the dose? Should we change to a different BTK inhibitor? That's a very complicated situation, and it's really an individual discussion. Maybe we can even talk about more later, but it's really, there's no one size fit all. And thankfully there is no one size fit all, because we can be very specific and individualized these days. Thank you.
Thank you for your presentation. I have just a couple questions. Can you speak to the recommendations for reducing dosage to avoid the speed of toxicity in both ibrutinib and zanub? And then also recommendations for descendants of WM patients in terms of testing and markers.
I'm sorry, could you repeat the first question?
Sure.
It's about changing doses?
Yes, recommendations for changing doses to reduce the speed of toxicity.
Yes, I think that ties well with the first question. The question is, do we change the doses? Do we dose reduce? Do we try to change the treatments when there are side effects or complications? I think there's still an open question for debate. So there's no right and wrong answer, I guess. Again, it's a very specific and individualized answer. It's, should you try to decrease the dose? Should you try to change the treatment? I'll give you my personal bias. My personal bias is that when you don't have unlimited treatment options, and when you're trying to plan the treatment for decades in the future, I try to stick to the same drug as much as I can. So usually I think about dose reduction as my first step before jumping to another treatment, because I want to try to use that drug as much as I can and squeeze as much benefit out of it. Because again, as I said, we don't have unlimited options. And usually when you move to another drug, you don't think about coming back to the first one when you're talking about target therapies. Question over there.
Hi, Dr. Paludo. I'm asking a question on behalf of the virtual audience. So again, thanks to our virtual attendees for tuning in today as well. The question is there data to show risk of MDS or AML after bendamustine in treatment-naive patients who have only had one course of bendamustine?
It's a very specific question and went straight to the point. So out of all studies, or the studies that are available looking at the risk of MDS or AML after bendamustine, the ones that show the lowest, and the ones that had the 0%, were the ones that are looking at bendamustine and rituximab using first line versus second line or later. So it seems that the risk of MDS or ML seems to be lower when bendamustine is used first. And of course, the more chemo or the more chemo drugs are added, the higher the risk. So if you only had one treatment, your risk should be lower than if you had 2 lines of therapy or 3 and so forth. So again, this is a convoluted way to say that it seems that the risk of a secondary malignancy is lowest. It's the lowest when you use bendamustine earlier in the treatment course. But all these studies have some limitations, so it's really difficult to look at that and have a precise answer to give. Okay. I think we'll take one for that microphone.
Thank you. Question, it was a great summary, but if you have both gene mutations, particularly the CR, CR4, where would you go? What would you recommend to a patient?
Yes. So the best case scenario is having the MOD88 mutation and not having the CXCR4 mutation, right? Having the two. Yes. So what we're saying is that that's in the middle. So having the two is in the middle, and not having the MOD88 mutation will be kind of in the third option. So having the two, it means that using a BTK inhibitor such as ibrutinib or zanubrutinib is still reasonable. As long as you have the MOD88 mutation, it's still reasonable to consider a BTK inhibitor. Although we know that the efficacy might be slightly decreased because of the CXCR4 mutation being present there. But it all boils down, I mean, the detailed discussions on should I use this drug or that drug, it's really individualized, and that usually goes back to the side effect profile more than the efficacy itself. But having the CXCR4 mutation would not prevent me to recommend a BTK inhibitor. Kind of a summary of it. Maybe you'll take one in the middle and then one there.
Sure, thank you. What is the current research or thinking in terms of WM as it relates to familial or genetic cancer, and what should we be telling our kids and grandkids? How do they look for that?
It's a great question, and I think that there was a very nice discussion in the previous presentation about the familial Waldenstrom. So it's not something that's passed from one generation to another, but we know there are some families, some rare families that have a higher risk of developing Waldenstrom's in that family. There's a slightly higher risk of first-degree relatives to develop a type of lymphoma or myeloma or Waldenstrom's as well. But we do not have a specific test, and we do not recommend screening family members specifically. Waldenstrom's is a very, very rare disease. A first-degree relative still has a very, very low chance of developing it. It's just slightly higher potentially than the general population. So we do not have a specific screening for that. I would not recommend specific screening for that. I know there are some studies, and I believe there is a large study at Hopkins, I believe, looking at the familial Waldenstrom. So they're looking for families with Waldenstrom's in their lineage for studying. So there is some studies, but it does not change the screening, it does not change the diagnosis, and does not change the treatment options, at this point at least.
Can you give an overview of where we are with CAR-T and bispecific antibodies?
It's a great question. We were talking about CAR-Ts earlier. I think we are a few years out before we get there. So we have been using CAR-Ts for a lot of other types of lymphomas, including some indolent lymphomas, such as follicular lymphoma, for example. Think about CAR-T as you think about transplant. It's not an option for everyone. It can be a quite toxic treatment, which has been showing some good activity in some other lymphomas. The data on Waldenstrom's is very limited. Very few patients have been treated, and we don't have a conclusive evidence or results yet. I know there are more studies looking to Waldenstrom's and CAR-T, but I think we're a few years out before we know anything more about that. So maybe come back in a few years and ask the same question, and then we can talk, I can have more information.
Yes, thanks. There's so many people who are receiving bendamustine and rituximab, but there seems to be tremendous variation as to whether or not those patients are given prophylactic antivirals and or antibiotics. Can you speak to whether or not that is recommended, or how do you decide as a doctor who should get that and who doesn't need it?
Excellent question. In the past, we did not used to use prophylactic antibiotics or antivirals. We're talking about usually Bactrim or acyclovir in patients receiving bendamustine. I think over the years I've been seeing more infection complications, not necessarily in Waldenstrom's only, but also in patients receiving bendamustine that have other types of lymphomas. So there are some practices that have adopted the overall just, we're going to prescribe prophylactic antibiotics, antivirals for everybody on bendamustine, and some have a more limited approach. In general, we tend to recommend, at least in my practice, use of prophylactic antimicrobials for patients that have a low CD4 count while on bendamustine. But I have colleagues that use on everybody, and I have colleagues that don't use on any patient unless they have an infection. So there's a quite heterogeneous practice on that standpoint. They don't come free of side effects, so any treatment has some side effects, including the antimicrobials, antivirals. So I think of it as selecting the patients that are at the highest risk based on the lowest CD4 count.
So you recommend testing the CD4? Because that does not seem to be common.
That's not part of the standard. I tend to check on that at least once during the treatment to make that decision. But it's not a standard practice. We'll go there, then we'll come back to the center.
What is the recommendation for doing genetic testing prior to therapeutics? They don't tend to do it in Eastern Canada.
So the genetic testing that I think it's fundamental to do before treatment is the MYD88 mutation testing. I think that's very important because that is the biggest, or I guess today, it's the main test that will define if I'm going to be favoring a BTK inhibitor, if the mutation is present, versus something else if the mutation is not present. The CXCR4 is interesting to know, but at this time, it does not change the management yet. So the MYD88 mutation test will be important to have done. Do we absolutely need it? The answer is no. Would it be great to have it? The answer is yes. Okay.
What about the MYD88? That is essential or not?
I think it's essential.
Yeah.
I think it is.
How can we change it? How can we change the therapy in Canada to include it?
It's a tough question. So maybe I'll pass the question for the next speaker.
Thank you.
Yeah, this is a very general question. Last week there was a lot of press about recurring melanoma and breast cancer, and there's a vaccine apparently with great potential. Is there anything in the light for lymphomas or leukemias?
There's been some, there are some trials looking at vaccines, viral therapies in lymphomas, T-cell lymphomas and B-cell lymphomas. I don't believe there's anything specific for Waldenstrom's that I can recall right now, but there is some studies looking at that in lymphomas. There are some promising results in T-cell lymphomas, so slightly different than the B-cells, Waldenstrom's that we're talking, but maybe in the future. Nothing that I'm aware of right now. Good.
Dr. Paludo, I have another question from our virtual audience. The question is, what is the function of steroids, for example, dexamethasone, in these treatments?
So excellent question. So steroids in general, steroids have a role in treatment of almost every subtype of lymphoma, including Waldenstrom's. Steroids, they can kill lymphocytes where the lymphoma cells come from, and specifically in the Waldenstrom's case, for example. So they have a role in the treatment of the cancer cells itself. They also have a role in other settings, but there is a potential role. Now the challenge is that the steroids that we use in the management of Waldenstrom's and other lymphomas are usually very high dose steroids that come with side effects. So we limit the use, but they have a role as an anti-tumor drug.
Yes, I'm one of the 1% of the Waldenstrom patients that develop Bing-Neill, and they currently have me on zanubrutinib. In your opinion, is that the best treatment? Has there been any clinical trials done on Bing-Neill?
Excellent question. So Bing-Neill is a very rare disease, so it's very difficult to study that. We know that BTK inhibitors have activity. There are some studies looking at ibrutinib working in Bing-Neill syndrome and show some good results. We know ibrutinib works well in the CNS. I don't think we have as much data about zanubrutinib working in the CNS, but as a class, it's potential that there is some cross activity. Okay. So didn't really give you a clear answer. I just went around in circles. But it can potentially be a treatment, but we know more about how ibrutinib works than zanubrutinib as for Bing-Neill syndrome. And I think we are running out of time. Is that? And I'll be happy to answer more questions later. Find me on the hallways and stop me, and we can chat more later. Thank you.
So thank you, Dr. Paludo. We appreciate your generosity of your time and travel to be here, and it's made a real difference for us. So thank you for doing that. Audience members, we really are looking forward to your evaluation of all of our programs, and if you're in the virtual audience, you have that screen that pops up to allow you to address it. If you're here, and if you're like me, you're not so good in those QR codes, but that is actually what we need you to do, is take a little picture of that QR code with your telephone, and it takes you to the questionnaire, and that input, again, is extremely valuable to us and helps in future presentations, so please take the time to fill that out, and maybe you could find a couple of kids who could help you manage to get there. Finally, I have just a reminder about filling those out, and that we will be accepting questions for the Ask the Doctor session that need to be prepared and then dropped off at the registration table so that they're available for tomorrow. So if you have questions that maybe you didn't get to ask here or more complicated, you'd like to drop them there, that's the way to get them addressed by the Ask the Doctors session. And I think that's all I need to do, except that now we're headed for lunch. And then right after lunch at 1:15, Dr. Brannigan will be presenting important information on infection prevention, something important to all of us. So we look forward to seeing you at lunch, and then at 1:15 with Dr. Brannigan back here. Thank you.